Welcome back, coding professionals and compliance-focused learners. I'm so glad you're here for another Masterclass Explainer. Today, we're tackling part 4 of our deep dive into medical coding, and we're specifically honing in on the ICD-10-CM coding guidelines for diabetes mellitus. You know, getting these specific endocrine codes right, it isn't just about passing audits or, getting claims paid. It's really about painting a highly accurate, completely comprehensive clinical picture of our patient's health. We've got a ton of absolutely critical ground to cover today, from rigid category structures and strict remission criteria to some pretty complex medication status codes. So grab your notebooks, clear away any distractions, and let's get focused. Okay, let's dive into this. Our roadmap for today's explainer covers 3 crucial pillars. First up, the ICD-10 code architecture. Second, we'll look at core coding directives. And third, we'll wrap up with long-term drug status codes. All right, Section 1, ICD-10 code architecture, building the code. Let's jump right in. Okay, so when we look at a fully fleshed out diabetes code, say E11.3219, for example, we're actually looking at a super precise 7-character anatomy. Let's just count it out methodically. Characters 1 through 3, they give us the category, which indicates the specific type or etiology of the diabetes. The 4th character zeroes right in on the affected body system. Moving on, the 5th character specifies the exact complications affecting that particular body system. The 6th character identifies associated manifestations. And finally, that 7th character dictates laterality if it applies. And this brilliantly illustrates how every single character tells a vital piece of the patient's story. Literally, missing even one character can compromise the entire medical record. Now, looking a bit closer at those first 3 characters, the categories, you absolutely have to know your etiology, right? Because the starting etiology determines your entire code path. Let's break them down. We have category E08, and that's used for diabetes due to an underlying condition. E09 is designated for drug or chemical-induced diabetes mellitus. E10, that's your classic type 1 diabetes. Then there's E11, which is assigned for type 2, or, and this is a big one we're going to revisit later, when the type is unspecified. And finally, E13 covers other specified types of diabetes. Choosing the right category right out of the gate, it's absolutely non-negotiable for coding compliance. So the crucial point here is that these diabetes mellitus codes are what we call combination codes. But what does that actually mean for you on a daily basis? Well, the official guidelines explicitly state that you must assign as many codes within these categories as necessary to describe all of the complications of the disease. You can't just slap on one code for diabetes and call it a day. You have to capture the type, the affected body system, and all associated manifestations in one comprehensive sequence. If your patient has multiple complications, you are strictly required to assign multiple codes from categories E08 through E13 to identify every single associated condition that patient has. It's the whole shebang. Let's move to Section 2 and see how this builds. Core coding directives, navigating clinical scenarios. We're kicking this section off with an early stage alert. Did you know you can actually code for type 1 diabetes before the patient even shows traditional symptoms? It's true. The ICD-10 guidelines specify that codes under E10.A, which stands for type 1 diabetes mellitus pre-symptomatic, are assigned specifically for early-stage type 1 diabetes that predates the onset of actual symptoms. It's a highly specific code, and of course, it relies entirely on precise, proactive provider documentation. Now, what's really interesting about this slide is the massive compliance trap sitting right here. Seriously, this catches even seasoned coders totally off guard. There is a distinct, critical clinical difference between the words remission and resolved when you're reading a provider's chart. Code E11.A is specifically for type 2 diabetes mellitus without complications in remission. But if a doctor just writes that the patient's diabetes is resolved, well, that is absolutely not synonymous with remission. If the documentation is fuzzy or unclear, you can't just guess. You must query the provider to clarify if the condition has actually achieved clinical remission. And to properly justify querying your provider or coding for remission in the first place, you really need to understand the strict clinical parameters required. Type 2 diabetes remission is clinically defined as when a patient's blood sugar levels return to a safe, non-diabetes level. To put that into perspective, we're talking specifically about an HbA1c of less than 6.5%, long-term without the need for any glucose-lowering medications for at least 3 months. It is a very high clinical bar to clear, and that's exactly why the documentation in the chart needs to be crystal clear before you even think about assigning that E11.A code. Okay, let's cement an absolute rule right here. I like to call this the golden default, because if there's one thing auditors love, it's a completely unambiguous rule.
If you're reviewing a medical record and the provider's documentation is completely silent on the type of diabetes, meaning they literally just scribble down diabetes without specifying type 1, type 2, or secondary, the default assignment is E11 for type 2 diabetes mellitus. This rule is ironclad, guys. Even if the record notes that the patient uses insulin, if the specific type isn't documented, E11 is your mandated starting point, no exceptions.
Moving on to our final section, Section 3, Long-Term Drug Status Codes, Category Z79 Rules. Think of this as your vital, everyday cheat sheet. When a patient with diabetes routinely uses medication for control, we have to report supplemental Z codes to tell the full story. Let's methodically map these out. For long-term current use of insulin, you're going to assign Z79.4. If they're managed on oral hypoglycemics, the code you need is Z79.84. And for injectable non-insulin anti-diabetic drugs, you're going to use Z79.85. These status codes aren't just nice-to-haves. They are essential, mandatory additions to your primary E-codes. But wait, what happens if the patient's condition requires multiple medications? Well, the guidelines are exceptionally clear on dual therapy reporting. If your patient is treated with both oral hypoglycemic drugs and insulin, you have to assign multiple status codes to maintain full compliance. You will report both Z79.4 to capture the insulin use and Z79.4 for the oral medication. Basically, you need to assign as many Z codes as necessary to capture their complete pharmacological management plan. So the crucial point to remember here, right before we wrap up, is the exclusion rule. You must never ever assign these Z79 long-term status codes for temporary insulin use. Let's say a patient is given insulin temporarily to bring down their blood sugar during a brief illness, or maybe during a surgical encounter. That doesn't qualify. The Z79 category is strictly and exclusively reserved for routine, long-term medication use. Assigning it for a temporary spike in the hospital, that's going to fail an audit every single time, for sure. So after breaking down that 7-character code architecture piece by piece, navigating the really tricky documentation waters of remission versus resolved, and perfectly mapping out those category Z79 drug status codes, are you ready to audit your next patient chart with 100% precision? You know, these endocrine guidelines might seem super dense at first glance, but by structuring your approach and really understanding the why behind the rules, you guarantee a level of accuracy that protects both your provider's revenue and your patient's real clinical histories. You now have the tools, the structured methodology, and the focused knowledge to apply these guidelines perfectly in your daily workflow. So take these rules, protect your patient's clinical histories, and keep up the highly accurate work. Thank you so much for joining me today, and remember to like, share, and subscribe to Decode Healthcare with Harshal. I will see you all in the next module.